Hello everyone and welcome to CK Med. My name is Clark and I'm going to be taking you through abdominal and pelvic walls and the clinical approach to both of those today. To start things off, I want to talk about the abdominal wall. First we're going to start from inside and then we're going to go outside and talk about some of the structures there, and we'll be using our essentials anatomy. So starting from the inside, we have our internal anterior abdominal wall. So this is, I'm sitting inside the abdomen and I'm looking out the front side of this person's belly. And so this is where our umbilicus is going to be lying, is right up here in this area up top. And we have some of these vessels that are running in this direction. We have this median line right here. And so let's talk about some of these different folds. These are embryological folds, and they're remnants of these folds that occurred during embryological development. But some of them do come up in clinical significance, especially when you get to year 2 and start talking about some of the pathologies. However, you are going to learn some of the pathologies currently near the end of this video. So to start things off, in embryological development, we have our wall, and I'm going to actually do a cross section of this. And so this is our wall of the belly, and this is our spinal cord back here, spinal cord here, and this is our abdominal wall. And we're going to protrude our belly out this way. This is our GI tract, so this is gut. I draw that in there. And this is the side wall. This is the left side wall, and this is the right side wall. And what happens is we want to bring these together in this midline point, and this is called lateral folding. And so we just kind of want to seal off the abdomen. And when they meet at this midline point here, this is known as your median fold. Now, your median fold not only closes off the abdomen, it's kind of this folding line that's running right here, but it actually closes off this structure, which was open before, and this is known as your bladder. And this is very important because if this remains patent and open, you actually will have urine that flows all the way up this tract and comes out the belly button, and this is known as a patent urachus. And so this structure that we ended up closing off this bladder is known as your urachus. Now that's something that's very important for embryological questions and anatomy questions, is a small child that comes in 3 days after birth and urine is extruding out of their umbilicus or their belly button. Why is this? Well, that's incomplete lateral folds or closure of your urachus. That's how you answer that question for that particular subject. One other additional thing you're going to see later next year, actually, when you get to some of the pathology, is this is one common place that you're going to find a certain type of cancer called adenocarcinoma of the bladder. And this is your adenocarcinoma of the bladder, as I call it, and this is going to be found on the dome or the top of the bladder, which makes sense because we folded all the way down and closed off the top of the bladder. This is the top of the bladder, and so if I have cancer there, it's going to be due to cancer from the urachal remnant. And this is a very important concept actually for step 1, and so I'm going to give that to you as some nice cool information for you at this point. But please remember that if you have an infant leaking urine out of there, it's closure of the urachus failed or lateral folds did not occur. Lateral folds also is very important because it's where you get gastroschisis, when you have abdominal organs sticking out of the abdomen. And that's something you'll see in our abdominal section, but urachus is more important for bladder talking pathologies. Now next is our other fold right next to this, and this is known as your medial fold. And this is very important because in a baby in the womb, you have umbilical vessels such as your umbilical artery and your umbilical vein that runs up, goes into the belly button and out as your umbilical cord, which then attaches to the placenta, which attaches to the mother, gaining the access of blood from the mother to the baby. That's the kind of flow through there where this goes, and it goes up towards this direction. Well, what happens after you're born? You don't need blood from mother, and so therefore this vessel kind of disappears, and this is known as your medial fold, and that is your obliterated umbilical artery. This artery kind of comes in like this. It gives off your umbilical artery this way, and it also gives off your vesicular or superior vesicular or superior bladder vessel is what vesicle means. A vesicle means a circular sac of fluid or water, and so that's another name that we call the bladder. But this artery comes in, and the umbilical artery portion of this disappears after birth, but continues and leaves the patent blood vessel supplying the top of the bladder called your superior vesicular branch. And then the most important one, and this is why I actually have this in green, is known as your lateral folds. This is your inferior epigastric vessels, and this is this one right here. And why this is important, we'll be talking about in just a little bit, actually, when we're talking about our inguinal hernias. This is kind of our reference point that we need to discuss when we're talking about our inguinal ligaments. But as for now, your inferior epigastrics are vessels that come off of your femoral artery, and I'll be showing you that in just a little bit when we start talking about our pelvic blood vessels. If you check out our next video when we get to pelvis and perineum, I'll be discussing that in further detail as far as those blood vessels coming off of there. But your inferior epigastrics come off your external iliac before it leaves the pelvis and leaves the abdomen to become your femoral artery and veins that are found in your lower limb. And so the lateral fold is your inferior epigastric, and that is our reference point for our inguinal hernias. Okay, and we'll be kind of discussing what this Hasselbalch's triangle is in a later slide. So now what I want to kind of talk about is something called your rectus sheath. And so your rectus sheath is pretty much obviously the rectus abdominis, that's your abs. If you got a 6-pack or 8-pack, you're going to see your rectus muscles. And then if you have those oblique muscles, you're going to see off on the side over here, such as your external, internal, and your transverse oblique abdominis muscles. And so what is important is to understand what is above and below the arcuate line. So before I actually explain this diagram, let's go over and switch over to essentials anatomy, and I'll show you this more on a three-dimensional physical realm, and then come back to this diagram, and it will make way more sense. Okay, so here we are in our essentials anatomy application, and we're here looking at this man right here. Obviously I've removed his skin, so he looks a little abnormal, but we're really focusing here on our abdominal muscles and our abdomen. Obviously we're talking about the abdominal wall, so let's discuss this. So first things we want to identify is after we penetrate the skin and the subcutaneous fat, we then hit our muscle. And with our muscle, what are those muscles we hit first? So if I were to take a needle and stab you through your belly, or a knife to stab you through your abdomen, what is the process of structures that I'm going through? Skin, fat, subcutaneous tissue, and then we get to our external oblique muscle. So I'm going to be keeping these structures there on the left, but on this patient's right, we're going to be kind of removing those. So obviously the external oblique is going to be the one that is most external, which makes sense. And so you can see that the structure of this, these fibers are running down as if you're putting your hands into your pocket. That's the way they're describing these fibers of your external oblique. So it's kind of from a lateral aspect, it's down and in. Is the direction of these fibers. So if these were to contract, they would be moving your body in an oblique fashion from your right shoulder down to your left hip is how this side would be contracting and moving. Now if I go ahead and hide this, then we have our next structure, which is found under here, which is the abdominal muscles where the fibers are running in the opposite direction. If we just had our external, then it seems to see that we have our internal oblique. So external, then internal, and our fibers are running up this way. So they kind of do the opposite motion and would be aiding in the opposite external. External would be contracting your left shoulder to your right hip, and my internal on my right side would be taking that same direction. My external, or my left shoulder down to my right hip as well. You can see these fibers kind of continue, external one side, internal of the other. Same with the other direction as well. So let's go ahead and remove these, and now we can see a structure that's very, very important. And so this structure right here, this little thing right here, this is known as your arcuate line. And your arcuate line is this kind of anatomical line or structure that we like to differentiate what is if I were to stab someone here in this area up here in this location, I'd be going through different structures as far as their orientation than if I were to stab someone down here in this pelvic area or hypogastric area of the abdomen. And how you can see this is I have my next muscle up here, which is my rectus abdominis. So this is your 8-pack muscles or your 6-pack muscles of your abdomen. And you can see this kind of slips into this little sleeve right down here, almost like a kangaroo patch. And so if I were to do a cross-section above this line, this is the arcuate line, if I were to do a cross-section above this, we would have gone through external, internal oblique, then my rectus abdominis, and then you can see that behind it, I have my transverse abdominis muscle found right here. You can see it running behind my rectus abdominis. However, if I were to stab someone here in this lower part, we went external, internal, then the transverse actually snuck in front of the rectus, so transverse, and then rectus abdominis. So this just goes to show which or where is this aponeurosis, which is this wider part of the muscle, where is the insertion as far as orientation among the other muscles in the abdominal wall. So I'll go ahead and show you that cross section now, and now you can orient yourself as far as which tendons of which muscles are in front or behind each other. Okay, so now back to this diagram. This is our picture from above the arcuate line, so above where this rectus muscle dives behind the transverse abdominis. So you can see the fibers of our external oblique running here, our internal oblique running right here, and then our transverse abdominis fibers are running right behind here. So transverse, internal, and external. I know this picture kind of shows a little bit of break in some of the fibers of the internal. Don't worry about that. Just remember external, we have internal right here, and then rectus is the next muscle, and then we have our transverse right here. And so if I were above the arcuate line, I'd penetrate in this order. However, below we saw that the rectus abdominis kind of snuck in behind your transverse. So therefore, if I were to penetrate in this way, I hit all 3 tendons of the oblique muscles first, external, internal, and transverse, before then I would hit my rectus abdominis muscle. And so this is, I know, just a kind of a dumb concept found in anatomy, but it is actually questioned sometimes because it could be a clinical vignette of a 30-year-old female or whatever coming in to have and deliver a baby. And the OBGYN is in the OR with this patient, and they're going to perform a C-section. And so as they're cutting through the lower pelvic area below the arcuate line, the surgeon would observe what first 3 structures. And so this is very important to understand kind of which ones kind of come first, which below would be those 3, and above would be these 3 right here, leaving transverses through 4th. And so this is a very simple, straight anatomy, straightforward question, so don't miss that one. All right, so now that we've kind of covered our structures, let's go ahead and talk about some of the blood supply of the anterior abdominal wall. And this is very kind of straightforward. There's not a lot you actually need to know. You don't need to know every single one of these little things like the circumflex iliac and all these things. But first off, from the heart, which is found right up here. Here's our little heart. We give off a vessel known as your brachiocephalic. From your brachiocephalic, we give off a vessel known as your subclavian. From your subclavian, you have your axillary artery, which we will cover in upper limb. And so watch out for that video as we will cover that. But from your subclavian, there's a few branches that you need to know, and they actually are more covered in detail also in the upper limb, but one of them is known as your internal thoracic, which is this vessel right here. And this kind of goes internally behind the vessels, or behind the ribs actually, and then supplies off your blood supply to each of these ribs. And this is your sub and supra costal arteries that kind of come off of these guys. And then as it gets to the end of your thoracic cavity, the very last cartilaginous rib that comes off actually is, or cartilaginous web space of the thoracic cavity midline is going to be your musculophrenic artery. From your musculophrenic, you give off this superior epigastric. And what that means is I have a superior, or a vessel coming from the superior, coming down to my epigastrium, which is this region. So this is my umbilical region. This is my epigastrium. So things like your pancreas and your stomach and your spleen over here are going to be found in your epigastric region. And actually, spleen is more on your left upper quadrant, but you do have some of it running right here. But your stomach and your pancreas are found in this epigastrium. You have your umbilicus, and then you have a hypogastrium down here. So from above, you have this musculophrenic, which gives off superior epigastric, and it comes down to your umbilical region, which I'll draw with this arrow right here. From below, remember we were talking about our inferior epigastrics. Again, here they are. This is very important. This is a reference point for our inguinal hernias. But what this does, it comes from inside off of your external iliac before it comes into the leg and becomes your femoral artery. And this runs up this direction, and they meet at the umbilicus. So superior epigastric and inferior epigastric meet here in this center meeting place. And when we do the abdominal video, which will be coming up actually next week, this will be covered a little bit more in detail as to some of the things you can see, such as caput medusae. And that's something that's very important when you have liver failure and portal hypertension, which we'll be talking about that again in our abdominal video. But again, this is the meeting point of our superficial arteries and venous structures that are found here, that when you have venous involvement involving the same name vessel, superior and inferior epigastrics, you will see something known as caput medusae. And we'll be talking about that later. All right, so now that we've kind of covered the anterior wall, both the muscles and the structures and orientation of the fibers, and now the blood vessels, let's go ahead and open up that abdomen and look what's inside. Obviously, we're going to remove some of the organs because this is not an abdominal lecture per se, but it's more of what is the walls that line our pelvic organs and our abdominal cavity. And so some of the things that are very important and should stand out when you kind of take away all the organs is, in our abdominal cavity, we have a very kind of distinct section that is up on the top, and this is really your diaphragm. And that's why we have over here this entire diaphragmatic view. Then we have this kind of middle section that has very heavy muscles that are attached to our lumbar spines, L1, 2, 3, 4, 5. And these things are like our psoas muscle right here that will come into play in our lower limb. And then some things like our iliacus muscle. And that's something that combines with your psoas muscle to actually make your iliopsoas. And that's something you'll come into play on a test called your psoas test when someone has appendicitis. And we will, again, get to that in our abdominal video. But these muscles are very important for both your leg movement and your abdominal kind of crunches that you do beyond your abs out in the front. They allow for kind of rotation of your abdomen as well, and it keeps everything kind of stabilized as far as your lower back. If those weren't there, you'd have very weak back muscles and you'd have very bad arching of your spine, and that would be something known as lordosis. And that also will be covered in back and spinal nerves. All right, and then lastly, the bottom section is going to be our pelvis. We're going to be talking about that in pelvis and perineum, the next video following this one. So don't wait, but check out that video when you get there. But as far as our upper, we're going to talk about our diaphragm super quick. And this is something you're going to never hear the end of, but this is a muscle that obviously is for quiet breathing. And so whenever you're at rest and you're sleeping or you're snoring, the muscle that you're going to be mainly using for breathing is going to be your diaphragm. And how this works, when it contracts, it actually flattens. So here is our diaphragm right here in the resting state, and here is my lung right above here. So I'm going to draw my wonderful little lung that kind of follows just like this. And that goes up to the trachea and the other lung on this side. So what happens is these are kind of stuck together, almost strung together by a space called your pleural space. And this is sort of like a vacuumed space, so it's got some suction on it, almost like a suction cup. And so what happens is when this contracts and goes downward this way, it's going to pull on the outer surface of your lung, and that's going to then open up your lung nice and flat, like this, and this is my diaphragm. So now I have all this extra space that was able to suck in some air. And so this is some airspace like this that's going to fill in when this person contracts their diaphragm like this. And so what nerve kind of innervates this actually comes up from your neck or cervical region, and this is known as your phrenic nerve. And the actual roots it comes off of is C345, keeps the diaphragm alive. So always remember that phrenic nerve are those three roots. And it is very important as far as when we get to referred pain. I'll show you that at the end of this video. That will be talking about our phrenic nerve. Okay, so now that we've talked about diaphragm, well, what things happen with the diaphragm? Obviously, things like emphysema, which you'll cover more in physiology and respiratory section, those things kind of flatten our diaphragm, make it harder for someone to actually inspire and also expire as well, and require an increase in work of breathing, because now they have to just use all their chest wall muscles to actually open up the lungs and squeeze the lungs out, as opposed to using our diaphragm like a normal person would. But other things that also can occur are things like esophageal hernia. So this is where we have our esophagus and our stomach. This meeting place is known as our lower esophageal sphincter, or LES. And certain things that actually happen is we have this distinct kind of space or lower esophageal sphincter location, but if that actually moves up or slides around or moves around, or part of the stomach herniates through the diaphragm, we have these different types of hernias. And so one of them is known as your paraesophageal hernia, and you can see this. And what this means is we have alongside, or para, the esophagus, and it's a herniation. So that means we have part of our stomach that's herniating alongside of our esophagus. And you can see this kind of herniate over here. So this is our paraesophageal hernia. And how they especially emphasize this in questions is that esophageal or gastroesophageal junction actually does not move. It stays in the same place, yet I hear vowel sounds in the thoracic cavity, and so that is most like a paraesophageal hernia. The other one is a sliding hernia, which by its name, because it's sliding, means that that junction actually slides up. And you can see this. Look how far it is up here now. So this is part of the stomach herniating up, along with the esophagus being lifted up higher, and that junction has now moved, and that's known as a sliding hernia. And so really when the questions are asking about this, they say, oh, this person has shortness of breath, a little bit of chest pain, some burping, maybe some like GERD, like some burning sensation in their chest. Well, and then they go, oh, well, what we observe is that the junction either stays the same, but yet they're having a hernia-like sensation, or the junction actually moves. And that is the differentiation between these two hernias. And that's super high yield, almost free points when you get to a question that describes where that junction is located. All right, next are our last more congenital diaphragmatic hernias, and this is Bhakta Lac and the Morgagni hernia. This is quite low yield, but I just wanted to emphasize some cool ways to easily remember this within a few seconds. So we have our diaphragm that normally develops, and from this normal development, we actually have this membrane right here, and this is your this is the original basis of your diaphragm. And what happens is when we develop our diaphragm, it goes out this way and meets the pleural cavity, which is coming this way. And it makes this kind of red fibery area. And so that's like a large part of the muscle is created from this pleural peritoneal membrane. Well, if we leave this open and we don't actually hook those two together, then we have possibility of herniating through some of these areas. And it just kind of depends where they're actually located. So if I have something in the back like this, so this is the spine, so spine, and this is belly. So you can see, this is anterior and this is posterior. And so when we have something in the back that is actually herniating due to the diaphragmatic hernia, then this is a Bhakta Lac, and you can see that in the back. So Bhakta Lac hernia is one that is posterior lateral of your diaphragm. But if it's actually more medial and anterior, you can see that this is the sternum right here, and then we have this hernia that's located right here. This is M of Morgagni for medial. And so that is just a quick way to remember that where this is. And this is actually a little bit more high yield than Bhakta Lac, but what they'll describe is there's a herniation just deep or just behind the sternum, especially like the xiphoid process and stuff like this. This is known as your foramen morgagni. It should close, but if it doesn't, then you can have things kind of running through there. And what normally does is actually, remember we were just talking about your internal thoracic vessels. Well, internal thoracic turns into your what vessels? Superior epigastric. And where do they run through? They run through this foramen of morgagni. If it stays a little bit too open, other stuff can go through there. Lungs can go down and bowel can go up, actually. So please keep that in mind when we're talking about these different types of hernias. All right, and now that we talked about diaphragmatic hernias, that's the top part, let's talk about the middle area. So things around your umbilicus or your epigastric region. So your epigastric hernia is a hernia that pretty much has like omentum, which is your fat that's covering your bowel, or small portions of your intestine, and this is due to a defect in the linea alba. And so we'll show you what that linea alba is if you don't know what that is, but you have your rectus muscles that are running like here, and the way I always remember this is I just remember Jessica Alba has really nice abs, and that is going to be this line that runs right here. It's just kind of a tendon-like fascial tissue. It's literally just means white line. That's what linea alba means, but it is found right between your rectus abdominis muscles that run down the mid-abdomen. But I'll just remember Jessica Alba and her abs, right? Okay, so if you have a defect in this, you're going to be protruding out in the epigastric region, and this is known as a epigastric hernia. If I have an umbilical hernia, so this is my umbilicus, I'm going to draw this as a little square. If I have an umbilical hernia, then I actually have a little bit defect. So it's a failure of the midgut to return to the abdomen. So what happens in development, you can see this picture down here, is we actually protrude our gut out here. And this is called our umbilical vessel, or our yolk sac. And eventually this is going to come back. It's going to define a little bit, do a little folding to make the intestines, which you'll see in our abdominal section video. But what happens if this stays open is you'll actually have it protruding out just above the umbilicus. And this is an umbilical hernia. Now, when we protrude this through, so okay, here's our little baby, wonderful, he's smiling, okay, and here's his belly, and here's his little legs. I'm horrible at drawing, but we actually protrude out. This is the baby's umbilical cord, okay, umbilical cord, intestines and loops and everything comes out here, ta-da, and that's our yolk sac right here. So they should come back, but if they don't and nothing closes, then we actually herniate above, and this is an umbilical hernia. However, if the intestines stay within the umbilical cord, and then it's covered by this umbilical cord membrane, this is called an omphalocele. This is something, again, we will repeat when we get to abdominal section, but there are other things that occur in this abdominal wall. All right. So now let's get away from our upper and middle sections of the abdomen, and let's talk about some of the lower sections. And some of the lower sections are very important to remember that involve the wall are your spermatic cord and kind of where this process goes. And so you have to remember that in early development, the testicles are actually found in the abdomen, just like the ovaries are found in the abdomen of a girl. And so what happens is, here's my abdomen right here and my wonderful legs that come off, ta-da! Okay, and then we have our little scrotal sacs. I'm going to draw these. It's a wonderful picture. It's going to be great on YouTube, okay? So in development, we have our testicles on either side coming up here, and here, again, is my little box of my umbilicus. Okay, this is at dermatome height of T10. So if I have pain, if I poke my umbilicus, I'm poking my T10 nerve. I'm also, if I kick my testicles, I'm going to have referred pain to my umbilical area, or T10. And why is this? It's because all of these things develop. So we have our spine that comes out here and gives off the nerves and the blood supply and the venous drainage and the lymphatic drainage. All those structures kind of develop and hook up to the testicles like this. Ta-da! Here's all the vessels. Well, what happens when a baby boy is growing is the testicles make their way down here, come lateral to the inferior epigastrics, go through the inguinal canal, and make their way down to the scrotum. And so during this process, it's actually pulling all the arteries, all the veins, all the lymphatic drainage that is going to develop from T10. And so if you were to look in someone's abdomen and go, oh, what's this blood vessel that's running from the middle of the abdomen all the way down through this little lateral kind of canal and then into the scrotum, that is actually your gonadal artery or gonadal vein, or also known as your testicular vein or testicular artery. And so this is very important to know that the development actually drags all these things down. So if someone gets kicked in the nuts, they're going to be grabbing their abdomen in addition to down here as well. Why is that? Because it's carrying the same nerve fibers coming from this area. And again, more on referred pain a little bit later, and we'll be pointing out those areas as well. But as far as the spermatic cord, it's very important to know like kind of the original abdominal wall or kind of layers that we have here, and then what they end up making. So in black is all the different areas of or types of tissues that are found on the abdominal wall, and then what they turn into once the spermatic cord and the testicle actually grabs and takes it with it. And so the parietal peritoneum, which is the first layer that you meet, is actually going to invaginate and make something known as your processus or tunica vaginalis. Pretty much this is the most inner thing wrapping around the testicles because that's the first thing that they bump into when they're coming through here. So as they're coming from the inside of the abdomen, they have to protrude through this. The first thing they touch is parietal peritoneum, pulls it with it, becomes your tunica vaginalis. So if tunica vaginalis stays open and I have fluid that wants to come from the abdomen, if it stays open, it's going to be going through a patent tunica or processus vaginalis, and this is known as a hydrocele. And we'll talk about that in just a minute again. Transversalis fascia is just a type of fascia that's found a little bit superficial to our parietal peritoneum, and that becomes our internal spermatic fascia. Then we meet our internal abdominal oblique, and that becomes your cremaster muscle, and this reflex is done by scraping on the internal side of the person's upper thigh, and this will contract the cremaster muscle of the testicles and rise the testicles up closer towards the abdomen. And then we have our external oblique muscle or aponeurosis, and that becomes our external spermatic fascia. And then lastly, we have Camper's fascia, which is just kind of this fat that's like down here in the perineum, and we take that kind of fat with us, and that becomes our dartos muscle. So that's the spermatic cord. Why is this important? Well, obviously, we're going to get to this, and finally, we're talking about some of the clinical aspects, but this is known as your inguinal hernias. And the ones you need to know are your direct versus your indirect. Now, for some reason, the teachers decided to really mess people up and get you super, super confused with this. And so I'm going to actually explain this for you so you can actually answer the questions appropriately and actually know what is actually occurring. So let's talk about each of these. So we have our testicles up in the abdomen. And again, we said that they get pulled down and they're going to go through an inguinal canal, which is right at this point, starting here. Once they go through the canal, which is this, right here, so they go through the canal, they're going to come out. And now I can see it with my eyes on the outer portion, just above where their penis is right here. This is their penis. And so, yes, I did draw a penis on YouTube. Okay, so the inguinal canal comes out, and then I can see a protrusion if we were to stop right here. But then it continues down into the scrotal sac, and now it's pretty normal. So this is the normal direction of our testicular descent. However, if I have herniation away from this direction, this is more medial. So here's my abs right here. Here's my ab muscles. And here's my linea alba, Jessica alba. Woo-hoo. Okay, so we have our abdominal muscles right here. If I actually protrude through the muscle, and then it's going to exit out through my superficial inguinal ring only. If it's only exiting the superficial ring, going through the abdominal muscles right here, also called your Hasselbalch's triangle. This is a triangle. No. Okay, so this is called Hasselbalch's. Also, if you want to think of someone else with abs instead of Jessica Alba, you can think of David Hasselhoff. But, well, this is his cousin Hasselbalch. So Hasselbalch's triangle, if you go through this, you're going to be covered by your external spermatic fascia only. And this is known as your direct inguinal hernia. Where, on the other hand, with your direct inguinal hernia, you also have the details that you should know are your where is it associated with your inferior epigastric. So let me actually remove some of the writing here and redraw this for you. So if I were to actually draw this, so here's my Hasselbalch's triangle. And Hasselbalch's triangle is made from the lower portion is actually the inguinal ligament. The actual hypotenuse of this triangle are your inferior epigastrics, so they run woohoo like this, inferior epigastrics, and then the medial border is actually your rectus muscle, so your rectus abdominis muscle. And so if you herniate through this triangle, you skip out on this area right here. This is known as your internal ring, and you just go through your external ring. And so the way I kind of describe this is I pretend I have a wall, a big wall like this. And the wall kind of exceeds all the way over here. This is my wall right here. I'm going to redraw this very thick for you. So you see this giant wall, and on the side of the wall, I see a little door, a door. Okay, so I'm on the other side of this wall, and what I want to do is I want to go on the other side of this wall, on this side of the wall, and I want to jump through this hula hoop. This is known as our superficial ring. As an end result, I want to get to that superficial ring. I want to do that hula hoop, go through it. However, how do I want to do this? Do I want to break through the wall like the Hulk, then go through the hula hoop? Or do I want to actually go through the door and then through the hula hoop? And that is the actual description of our different types of hernias. The direct is like the Hulk, and it goes right directly through the wall and goes then through the hula hoop, and you have a direct inguinal hernia. Where instead, if I go all the way out over here, on the side of the wall, which is the wall edge is your inferior epigastrix, I then can go through my internal ring or the door, and then I can make my way out here and go through my hula hoop. This is the easiest way of kind of remembering where these are going. So here's my little bow piece, and I go, oh look, here's the door over here, which is my deep inguinal ring, as that circle right there. Go through my canal, and then I come out of my superficial ring, which is out here, which is hula hoop. Okay, so this is actually a way that you can remember your indirect and direct. And so let's talk about some questions of how they do this. So they say, oh, I have a 2-year-old infant that comes in with a inguinal swelling. Okay, so the surgeon goes in and opens up that inguinal swelling, and notice is that the swelling goes through the deep inguinal ring and then through the superficial inguinal ring, and he asked you, where is the deep inguinal ring located? And they could say, oh, well, the deep inguinal ring is lateral to the inferior epigastrix. That is a plus. Da-ding, you got that point. They could also say, oh, well, what type of inguinal hernia this is? Well, that's my indirect inguinal hernia, as we were talking about before. And then, oh, we can also ask, what is it covered by? Well, if it's going through the same route as the testicles, it's going to be covered by all 3 layers of fascia, like the testicles are, which pretty much spell out ICE. So if you remember this is a mnemonic from first aid. So shout out to first aid for bringing that information to us. But if you remember your internal spermatic, your cremaster muscle and fascia, and external spermatic, ICE, that is what this is all going to be covered by in an indirect inguinal hernia. Where direct is straight up only going to be covered by your external spermatic fascia. Also, your external oblique muscle was the original structure. So please remember that's important, what they're covered by, what's the route that they're taking, and then how to identify their location by the inferior epigastrix. And if you're medial to this, if you're medial, which is here, you're going through that triangle. And please remember David Hasselhoff's cousin, Hasselbalch, and that's Hasselbalch's triangle. All All right, so hopefully that makes sense. This is pretty much a free point if you can understand these different types of hernias. I know they're taught really poorly and kind of confuse you on how the direct, because they're just using the words and not actually drawing or making an analogy for those structures. Okay, so this is everything we kind of just talked about in reference to where they are located. So lateral to inferior epigastrics is going to go through your deep and then superficial. That's your indirect inguinal hernia. Also, pretty much how we describe deep to superficial ring, that is your inguinal canal. That is the canal the testicles go through. So if it goes the same route as this spermatic cord, it is an indirect inguinal hernia. It's going to go all the way out through that door on the side of the wall instead of breaking through it, breaking through that Hasselbalch triangle, like our direct inguinal hernias are, which is also medial to the inferior epigastrics. Okay, so let's talk about some of the other congenital defects of the testicles and inguinal canal. So we have something known as cryptorchidism, and this is pretty much a defective gubernaculum. And you might go, wow, that's a really weird word. What is the gubernaculum? Well, this is just a fibrous tissue that pretty much attaches to the bottom of the scrotum, and this is pretty much the thing that pulls down the testicle into the scrotum, is your gubernaculum. It's really long, and then it starts to shorten and yank it down into the scrotum all the way through your inguinal canal and everything. And so there's actually a YouTube video. You can, I think it's called the hunt or something for the testicles, or this bringing the testicles to the scrotal sac, or finding the scrotal sac, or something like that. It's this little weird cartoon with a little fuzzball. It's very weird. But anyways, if you have a defective gubernaculum, you're not going to yank down on the testicles and bring them in there, so it will be a undescended testes, and that's what we call cryptorchidism. And pretty much the treatment for that is before age 2, we want to bring that down, or else it's going to kind of dissipate / increase risk of cancer if we leave it in there for greater than 2 years. Someone that has ectopic testes just means the testicle is located in some weird place and not in the scrotal sac, and it's not something in the direct path that it was following up from the abdomen down through the inguinal canal. If it's not anywhere along this path and it's somewhere over here or on top of the bladder or something, then that's called an ectopic testes. Congenital hydrocele. So again, like we were talking about, remember when the testicle went through the abdominal wall, the first thing it touched was your tunica vaginalis. Also, your parietal peritoneum was the original structure, but now it's called your tunica vaginalis, which is this pouch like this, and now the testicle's in it. If this stays open, fluid is going to fill up in this place, and that's going to cause a hydrocele. And how do I differentiate? Hydrocele is I take a light and I put it against the scrotum and it glows, similar to if you're in the dark or whatever and you're a little kid and you put a flashlight against your fingers or your cheek and it glowed like kind of red color. That's exactly what a hydrocele looks like. You don't believe me? Google it. Varicocele is the next thing. This is something that does not light up when you shine a light onto the testicle, so that differentiates from hydrocele. And this is a pampiform plexus. So here's my scrotum right here, and then we have our testicle found within there, and all the external structures for the testicles and the loops and everything like that. Well, we also have our venous drainage, and this is sort of like a network found all around the testicles, just like this, almost like a net. And if we have obstruction way up top here from, remember, T10 height, T10, way up here, this is our testicular vein. We can, if we have some sort of obstruction to this, then it's going to back up blood into the vein, and it's going to cause all these veins to dilate, and they're going to be very dilated. And this is what we call a bag of worms. And this is your varicocele. This is really bad because your testicle actually can die and increase the risk of cancer. So we want to kind of fix this. And now this is kind of interesting, and this is something that actually more comes up in abdomen, but why are we getting varicoceles? Why is there this strange obstruction? And so this comes down to this very strange anatomy, so please remember this. And here is my inferior vena cava, IVC, inferior vena cava. Off my inferior vena cava, I have a vessel called my renal vein, and that comes from my kidneys. Haha, kidneys. On the left side, not the right, on the left side, the testicular vein actually plugs into the renal vein and then goes into IVC. On the right side, it just goes testicular vein. And so, if I have something that obstructs this, such as my superior mesenteric artery coming from my aorta that runs right here, this is known as my nutcracker syndrome. And this is something where if someone loses, this is usually a classic case of a 35-year-old, used to be obese patient, has lost 100 pounds in the last 2 months due to excessive exercise, and now is complaining of swollen left testicle. This is due to nutcracker syndrome, and this is when I have my artery, and my artery was lifted up by fat. Fat was holding this up and allowing for this renal vein to continue through this kind of archway. But if I lose the fat, then this artery kind of squishes up on my renal vein, and then I have an obstruction in this area, and that backs up into my testicular vein, and then I have my bag of worms, varicocele. So that is how a varicocele usually comes to be. All right, so now on to the last portion of our slides. Now that you should understand are some of the areas involved with the abdominal wall and your pelvic area as far as dermatomes. So hopefully by now you should know what a dermatome is. And so these are our nerve roots of our body wall that have come out from originating from our embryological alignment of our nervous system. And so some of the ones that you should remember are your kind of landmark locations. So T4 at the nipples, T7 at the xiphoid process, T10 at the umbilicus, and T12 just around in your hypogastric area. This is pretty much the top of your pubic symphysis. Your pubic bone is where you're going to be feeling. Just above that is where your T10 dermatome are going to be found. Okay, so we've been talking about this a couple of times. So referred pain, since we're doing just abdomen and pelvis, we're going to be talking about some of the organs here. So we'll come up to this later on, but one thing that you should know is around your umbilicus, which is this area right here, T10, you're going to have things such as ovaries as well as testicles in a man. Obviously, this is a man, and well, actually, I don't know what he is. He doesn't have anything there. But ovaries and testicles are going to be referring to T10. And some of the other things, so like urinary bladder, are going to be found here. And then your ureter kind of can come down here, but also can go to different areas. But usually ureter is this flank pain in the lower right or lower left quadrants. And then other things that could come into play as important is some of the bladder structures can actually go all the way around to the different areas. So if you can remember, your urinary bladder is very low in the pelvis, and so it can actually orient some of the lower, like sacral roots down here, because the reflexes and all of the parasympathetics and sympathetics that go to your bladder are found from your sacral plexus, and so those are going to be sacral roots, and the sacral dermatomes are here on the butt and the upper posterior thighs. Okay, so that completes the actually quite most boring video of your abdomen and pelvic walls. All of them should be quite a bit more interesting than this. I know this is very low kind of clinical relevance here compared to some of the other videos, but thanks for watching. Don't forget to subscribe and look out for our next video, pelvis and perineum.